connection with biomedical therapy. And this talk will be given by Kirk Stewart from the Mercator Med Systems. And he'll speak about the Mercator Med Systems approach.
Thank you. Thank you for inviting me and for inviting Mercator to be part of the conference. I think it's fascinating how some of these old surgical therapies come back around as interventional therapies, and frankly that's how we got involved in this as well. Sounds like somebody in the audience during the last live case anticipated a little bit what we're doing, and Dr. Sabatka gave a very brief description of it. Mercator started as a company that's based around adventitial drug delivery. And so when interventional hypertension therapy began to sprout, as it were, we were in a very good position to take advantage of this, and looking back at some of the old therapies really helped us to propel something forward. I also, by the way, will disclose that I'm President and Chief Technology Officer, co-founder, and on the board of Mercator Med Systems, so I'm slightly conflicted. Of course, none of this work today, or potentially some, but none of this could have been done without some of the pioneering work that was done back in the 40s and 50s by a group of physicians around the world, really, where they were looking at splenectomy, sympathectomy, surgical procedures to go in and cut these renal sympathetic nerves and the splanchnic nerves in general. And the patients that they were looking at, while of course they didn't have the advanced medicines that we have today, rather mirror in some cases the patients that are resistant to drugs today. And I point to group 3 in the Smith and Thompson article specifically, who had 30% survival rates at 5 years on the best medical therapy, and with surgical sympathectomy, that could have been increased, or that was increased to 80% survival rate. So even back in the 40s and 50s, there were good therapies, or there were good proposed therapies. I'll point out in a moment some of the bad, of course, of those therapies, but you had patients, for example, this woman who had onset of hypertension, toxemia, pregnancy, severe headaches, nausea and vomiting, blurred vision, complete incapacitation, and was confined to bed for 8 months prior to surgical denervation. And after surgical denervation, she has 13 years, reported here, of a good life. So some of the questions that have come up about renal sympathetic denervation and renal denervation in general is how long could this possibly last? Based on some of the surgical results, it could be permanent. Of course, the evolution of the renal denervation that's taken place over time has really taken advanced steps, particularly with the little orange bars on this slide, the percent death that was happening with renal denervation over time. As you can see, obviously some of the earlier procedures led to percent improvements in the 70 to 80% range. Unfortunately, the mortality rate due to surgery was in the 15 to 30% range. So these were very obviously taken out of practice when effective drug therapies came along. And now, of course, the effective interventional therapies have come along to show that this was a good idea. It was just not well accomplished with surgery. This is familiar to everybody here at this point. The nerves surround the renal artery. They're seminal in the initiation and maintenance of the hypertensive process, and they're directly accessible with an adventitial delivery catheter like what Mercator has pioneered over the years. Getting right into it, the Bullfrog microinfusion catheter is used to reach and deliver drugs into the adventitia. It uses common balloon inflation techniques using indeflators similar to what you would use with an angioplasty balloon. The balloon inflates to 2 atmospheres, and it has a pressure governor on the hub of the balloon so that you can't overinflate it, thereby damaging the blood vessel. When you inflate the catheter, it moves from a shielded position into an inflated configuration, pushing a needle, a microneedle, through the artery wall and into the adventitia. One of the big questions that we always receive about this is poking holes in the artery. That doesn't sound like a wonderful idea. Don't you get a lot of bleeding? I'll point out that this is a 35 gauge microneedle, 130 microns in diameter, and we haven't had any perivascular hemorrhagic events in more than 200 animal cases or 30 human cases. I'll also point out that 19 of those human cases involved injection into the coronary artery adventitia of stem cells. So even injections in coronary arteries using this catheter are very safe. It allows, therefore, targeted delivery into the renal sympathetic nerve sheath. The catheter is 510K cleared in the US, and we're reaching CE mark approval in Europe in the coming months. And catheters are available for arteries down to 2 millimeters, so we have applicability potentially in patients that are like chronic renal failure patients. The way the catheter works, just a little diagram. The needle is held perpendicular the entire time while the catheter is snaked into place. We begin inflating, and it pokes the needle through the vessel wall. The needle length is specifically sized to pass the external elastic lamina of the blood vessel, thereby reaching the adventitia and perivascular tissues. And then when we inject, we only have one needle on the catheter. We only need one needle on the catheter. That way we don't have to contend with paths of less resistance by two needles deploying through the artery wall. When we inject, we see circumferential and longitudinal coverage of the area that we're injecting into. And if you've ever dissected a renal artery or dissected down to a renal artery, you know that it's surrounded with this connective tissue that when you deliver into the connective tissue, you're really surrounding all of the nerves. You're hitting that envelope. What this looks like in preclinical practice, we're not yet in the clinic, but we're well along in our preclinical studies, nearly completing and reaching FDA discussions soon. The guide catheter is put in place. The bullfrog catheter is snaked up into place. One can see where the bullfrog catheter name comes from when it's inflated in the chin, so to speak, pushes against the opposite side of the vessel, deploying the needle through the vessel wall here. Now, to detect positive injection, we put contrast media in all of the drugs that we inject. This isn't a big issue with contrast nephropathy because we're delivering on the order of 0.2 milliliters of contrast with that drug. The beginning of the injection is visualized so that you positively assess that you're out in the adventitia, and then we continue injecting. And here we're doing 2 injections, as you can see. 1.5 minutes for each injection and 3 milliliters for each injection in this case, completely coating, completely bathing that renal artery adventitia and perivascular tissue, creating no compression or hemorrhage along the blood vessel, and bathing the target nerves with the drug specifically. Now, the question, what's the drug? Somebody mentioned phenol and ethanol as potential agents that could be injected. We believe that that's a little too aggressive and that there's more specific drugs that can be delivered. And as Dr. Sabatka pointed out, we're delivering guanethidine. It's an old, as we would say, or as you hear on the radio, an oldie but a goodie. It was